vascular system, we started talking about acute MIs. So my question for you, Klein, is, okay, what is the most indicative lab test of cardiac damage?
Oh, he know that. He know that.
Do
Yeah.
you want me to get a harder question?
No,
Is
my
that what
question is up. So
Okay. So here's the scenario. I come into the ER and I'm having chest pain. Jay, you're the triage nurse. What you gonna do?
I'm gonna ask about history.
What in my history?
When did you start having pain?
Okay.
4
4 a.m.
Describe the pain symptom.
My chest hurts.
What were you doing when the pain happened?
Can't tell you.
Why not?
Personal. What else you gonna do?
Order EKG.
Okay. You're gonna order is maybe
Talk to the doctor about someone.
Okay, an EKG. What are you looking for on the EKG?
ST, looking for the ST segment for any elevations or something like that. Yes, ST elevation.
Changes.
Yeah,
Don't
changes.
just say changes. I'm looking for ST changes.
Yes.
Okay. Well, if I don't have ST changes, does that mean I'm really not having an MI?
No, that doesn't mean that. It could be just normal.
Okay.
Then of course, we'll look at the troponin.
Very good. So troponins. So when you look at troponins, you're going to do one, but what are you kind of looking at with my troponins?
Let's see if it's one or more.
Yeah, you're wanting the trend. So, we'll do it then, and then we'll do it again in a couple of hours. We're looking for that pattern. So very good. History, EKG, labs. Now, will you please select someone else to tell us about some other ways we evaluate cardiac function?
Kill.
Defibrillator.
Kill.
Okay, so that's fine. Those are our 3 main ones, but we have other ways that we evaluate. So how about let's start with an echo. What does an echo do? What's the purpose of doing an echocardiogram? Monitor. And you can phone a friend if you need to phone a friend.
I do.
What friend do you
Take a few
want?
seconds and try first.
I ain't got no friends.
Don't worry. I'll come. Don't you worry about Kim. I got Kim. Okay. Sheena, here's an echo. What's the purpose of an echo? You can phone someone. Josh is a good friend.
You use the echo to show mobility and contraction or conduction.
Yeah, it shows us how mobile the heart is, how the valve's doing. And remember I told y'all last week what y'all needed to know about EF?
It shows you the ejection fraction between.
And what's normal ejection fraction, Josh?
50% to 75%.
50 to 75%. A good number is 65. If you're 65 and above, you're good. Okay? So describe to us what the EF is. Like in real people, if you had to describe it to someone who didn't know what an EF is.
Just how much output your heart is.
Okay. Yeah, so how much blood is actually going out and perfusing to the body. So if you know a normal is 65%, when someone tells you your patient has an EF of 10, you kind of see why you should be like, ooh, got some issues here. Okay? So an EF is a really important thing to do. So Joshua, will you please select someone else to tell us some more labs or tests or anything we might do to evaluate the cardiac system?
Michelle.
Hey, Michelle. So, we've talked about person comes in with chest pain. We're still trying to rule out, is it an acute MI or are we just some angina? What's kind of going on here? Okay, so we've done labs. We have looked at the history. We've done the EKG. We might possibly have ordered an echo. What's something else that we could look at to let us know what's going on?
You could look at potassium levels, calcium, and mag.
Absolutely, because what will those cause if they become imbalanced?
Fluid electrolyte imbalance.
Yeah, electrolyte, they can cause dysrhythmias, which remember dysrhythmias sometimes can cause chest pain. Absolutely. So let's talk about a stress test. So Michelle, will you please select someone?
Sam.
Okay. Why do we do a stress test?
Well, it just stresses, or it puts their heart under stress to see how good it works under stress.
Very good. So when will we not do a stress test?
If their like troponin is elevated,
Right, because what does an elevated troponin show us?
it shows that
Yeah, it's damaged. Do I really need to stress that heart out? Absolutely not. Okay? So before someone goes down for a stress test, what do I need to do as far as medications?
You need to hold like the vitamins and stuff, like they can have their, like their blood pressure medicine or something that's like particular to that, like, I guess, pertinent situation, but they need to hold like other
Okay.
medicines until
So we would give like blood pressure medicines, right? Okay. What medications would we not give?
beta blocker.
No beta blockers. What's it going to do?
Decrease the heart rate.
Yeah, it's going to decrease that heart rate. Remember, our whole goal is to get the heart rate up. So we want to make sure we especially hold your beta blockers, your DID, your calcium channel blockers, anything that's going to lower that heart rate and keep it lower. We don't want to give until after. We do want to give it, but just not yet. Okay. Another question that was really good: diabetic meds, should I give or should I hold for a stress test? What are your thoughts on that?
I would say give.
Yeah.
Okay. Are they NPO? Aren't they NPO after clear liquid
Yeah, wouldn't
breakfast?
you wanna check it?
What happens if I give Novolog to someone? How soon is that going to affect their blood sugar? Within, y'all are hurting my heart. You don't know your parameters. There's a test question on that. Okay. So like your Novolog starts working in under 30 minutes. So let's say they have AM Novolog to give with their tray. Would you give that?
No.
Tell me why, Jay. Use that common sense and tell me why.
Well, because,
Are you going to give them their tray?
well, no, I mean.
No. So you don't give them their insulin. Think about it. If they're not eating, let me not do that. Now, if it was a long-acting, such as Lantus, long-acting, when does that peak? Look at y'all. It doesn't have a peak. Remember, it keeps them the same. Okay, let me write my notes. Lantus, Novolog.
We got you.
Oh, we already got the drug list. You can't add them on it. We already got the drug list.
Well, you were supposed to know that before you got here. Okay, but see, like that medicine, it doesn't peak, so it would be okay to give something that's not going to peak if I'm just keeping them where they're at. So you see, it kind of depends on the situation there. Okay, so now, so y'all told me a stress test, an echo. Let's talk about a cardiac catheterization. Okay, Sam, pick somebody. Sharon, here's my question. What's the purpose of our cardiac catheterization?
I know it looks like arteries.
That's and
And
what else I got in there besides some arteries? Oh, Frank, it's fine. Let her help you out.
check the blockages.
Okay, we're checking for blockages. The left side, right side, coronary arteries. Okay, so prior to getting a cardiac catheterization, I need to get 3 consents. Why? What are they for?
Well, one of the consents are like if something happens while in there, they can like just go ahead and do it. They don't have to like.
So one for
Start.
interventions,
Yeah.
absolutely. Okay.
Oh, one for blood
One for, why?
because they might need blood.
Why do you think they might need blood?
Um,
You can phone a friend. It's okay. This is learning, guys. It's not like you got 3 weeks where you test. It's not test now.
figure it out.
Because what are we going to go through to get to the heart? Yeah, an artery. So remember, anytime you're involved with artery, there's always a potential for bleeding. Okay? And then what's that last one for? Blood, interventions. Remember
the actual.
cardiac catheterization. Absolutely. Okay? Will you please select someone? Okay, what lab work do you want to look at before they go down for a cardiac catheterization? Why?
Just to see where their body comes at.
Absolutely. That's not it though. Give me some more. Give me some more.
Do you mean creatinine?
Oh, why?
Just for the use of nephrotoxic agent.
Yeah, remember, we're gonna use that contrast dye. And that contrast dye, like you said, is nephrotoxic. So if they have impaired VUN and creatinine, what does that mean to that dye in those kidneys?
It can cause damage.
Yeah, it's just gonna sit in there longer, so then you run the risk of like acute kidney failure, which can lead to chronic kidney failure. So we wanna know what their VUN and creatinine, but let's say you looked at your patients and they were abnormal, then what would you do?
You would want to call the physician.
And what would you anticipate orders for? You can phone a friend, you've done awesome. So tell me, what orders would you anticipate if someone had an elevated VUN and creatinine that they would order? Why?
So that you can get the kidneys working.
Yeah, we're gonna try and make them work, absolutely. What else?
Weakness.
Why? You know, I'm always gonna ask why.
Oh, yeah, perfusion. It increases, yeah, it's a, bronchodilator, but
It-
it also increases perfusion in the kidneys.
Absolutely, it is a bronchodilator, so, but we found its off-label use is it helps with perfusion through the kidneys, and it just offers some protection right there. So absolutely. And if it was too bad, you know, we'd always call the kidney doctor and say, hey, you know, we want you to come up here and consult, because we have to make sure that the benefits are going to outweigh the risk right there, okay? So, post-op from a cardiac catheterization, select someone for me. Okay, here's my question for you. They come back from a post-op cath. You're receiving them. What are you gonna make sure and check?
I'm gonna check the site and check on
What are you looking for at the site?
like some bleeding or frozen or hematoma.
Absolutely, okay? And then vital signs, and what one other thing you're gonna check? Maybe two other things. How do you know you got good perfusion to the affected limb? Okay, in addition to cap refill? Yeah, check your pulses, because remember, you made a little X before they went down, so it's easy for you to find. So you just put your fingers on there, and if it was a +3, should it be a +3 now? Yeah, so you do that, and you look at it, and remember, what color should it not be?
Blue. Oh, I'm sorry.
That's right, no blue, no gray, because that's a sign of poor perfusion. If it was warm prior to, it should be warm coming back. The other thing you might listen to, if it was an older adult, listen to their lungs, because sometimes we do use a lot of fluids in there, and then that way, if they start filling up, then we could definitely address that issue, okay? So that's kind of where we left off last week. So let's pick up. I call them check-ins. I do them almost every time. I'll say, hey, what did we learn last week? And I ask you questions to make sure.
And I studied a little bit.
Okay, awesome. It's coming, it's slow. But here's what we need to look at now. Let's say that we have determined that the individual has angina. It's not an acute coronary syndrome, but they just have angina, okay? So then we look at, well, what do we do? So the medications that you're gonna see used in taking care of someone who has angina, one would be nitrates, okay? I know I talked a little bit last week about nitrates, but remember nitrates, we use them to help increase collateral blood flow. It also is going to help with dilating the coronary arteries, and guys, it decreases the O2 demand. So here's the thing about nitro. I talked a little bit about it last week, but remember, before you give nitro, always ask about that ED medication. 24 to 48 hours, if you give it within, you could have a massive drop in the blood pressure, okay? So we want to make sure. Also, before you give nitrates, you better check the blood pressure. We know it's a vasodilator, and we know it's going to drop the blood pressure. What we're concerned with is how much does it drop it, okay? Other medications you can anticipate, beta blockers, guys. Okay? Before you give a beta blocker, you want to check your heart rate. The reason you want to check your heart rate is because we know with beta blockers, it will drop that heart rate. So we need to know, what is my baseline? If my baseline is 40, I probably don't want to give it. Okay? In addition to the heart rate, also check your blood pressure. Okay? But if I had to pick which one was the most important, it's going to be that heart rate. So what your beta blocker does, it increases myocardial perfusion. Okay? While reducing the force of the actual contraction, so the heart works smarter, not harder. Now, calcium channel blockers we like to give because, again, it enhances vasodilation. You also see us give some antiplatelets such as aspirin. Okay? So remember with aspirin, what it is going to do is it is actually going to make sure and inhibit platelet aggregation. And it's going to help inhibit the vasoconstriction that could be going on. So while aspirin can't dissolve a clot, it can help prevent future ones from forming there. Okay, so we'll give them aspirin. And then if we determine that this angina they're experiencing is from something like maybe cardiovascular disease or CAD, okay, then what they can do is they can go in there and they can do some procedures to try and help with their CID. For example, we could do things like a PTCA, okay? That stands for percutaneous, transluminal, coronary angioplasty. Essentially what we're doing is we're going into the vessel and we are cleaning out the plaque, as much of the plaque as we can, okay? Because if we can make the plaque wider, the blood has a bigger surface to flow through. So we can do things such as that. So that's what we do when we figure out that what they have is angina. It's not a true acute coronary syndrome. So acute coronary syndrome, that's like the latest buzzword. It could be unstable angina. It could be a STEMI or a non-STEMI. We talked about those last week. Remember we talked about STEMI, that's ST elevation. Okay? So what you have to realize is when you talk about acute coronary syndrome, remember that's just associated with a sudden rupture of plaque inside the coronary arteries. That leads to ischemia, okay? And eventually it leads to death if we do not restore the blood to that muscle. That muscle will actually die. So when you're looking at that, what I need you to realize is that the actual zone of infarction depends on three things. So this is a zone of infarction. This is where the MI actually occurs. So this area right here, remember your heart's a muscle, guys. So what happens is in this area, this tissue right here, it dies. It's dead. You can't do anything for dead tissue. You can't revitalize it. Okay? So this actual zone of infarction, how big this zone is, depends on three things. One, collateral circulation. Does the patient have it? Now, the way I like to explain collateral circulation is I explain it as a spider web, okay? You know what the spider web, it has a central area, but the spider has multiple ways to get to the center of its circle. Well, your body's pretty awesome, and what happens is your heart realizes that, or your body, I should say, realizes that when blood goes through this vessel, it doesn't get to where it needs to. So what happens is it diverts blood from that vessel to the surrounding vessels. And so over time, what happens is those surrounding vessels, they become bigger and stronger, and they're able to take on more of the workload, okay? It takes time to develop that. And not days, not weeks, years. So that is why your older people have better outcomes following an acute MI than your younger population, because they have had longer time to develop that collateral circulation. Okay? So if you look at like just statistics of your 70-year-olds surviving an MI versus your 40-year-olds, your 70-year-olds tend to do better because they've had time to develop that collateral circulation. So that's the first thing that depends how big that zone of infarction is. The second thing is how well do the cells function without oxygen. Okay? That determines how big that zone of infarction is. And then the third thing is, what is a myocardial workload demands? Okay, those three things determine how big that zone of infarction is. But the key thing, the takeaway point is, remember that once it's dead, we can't fix it. So what we focus on in someone's having acute MI is increasing the amount of circulating oxygen that they have and to reestablish blood flow, because we know this area right here, the areas around it are hypoxic injury and ischemia. We know if I can get blood that has oxygen in it to these areas, then I can fix those. And so it won't get any bigger. So that's our primary focus when someone's having an acute MI, is to increase the circulating oxygen. It's gonna slow the progression of that tissue death, okay? So realize in an MI situation, time equals muscle. Your heart's a muscle, guys. The longer it takes to get reestablished blood flow, the more muscle's gonna die, okay? The other thing you have to realize is sometimes physical changes, they don't occur right away. It can take up to 6 hours before some of these changes start occurring, okay? So we have found that people have the best odds when we intervene as quickly as we can. That's why it's so important for us to ask when they come in, hey, when did this chest pain start? Because we base a lot of our interventions on that. So when someone is having an acute coronary, or I should say, an acute myocardial infarction, let's talk about some of the treatments. Well, one, we know they don't have enough recirculating oxygen, so we're always put some O2 on them. And typically it's O2 per your hospital's protocol to keep your O2 sat above 97% or whatever your protocol might be, okay? The other thing that you can anticipate ordering, there's gonna be some aspirin there, guys. In this situation, we want them to chew the aspirin, okay? Because it gets in their system faster. Because remember, I told you with that aspirin, it's gonna inhibit that platelet aggregation, okay? It's also gonna help inhibit the vasoconstriction. So, it's gonna reduce the likelihood of a thrombus. Other things that we will do thrombolytic agents. You probably know these more commonly in practice, such as things like TPA. TPA, remember, that's tissue plasminogen activator, or sometimes it's called retabase. That's something that maybe in 201 when y'all covered strokes, you talked about TPA. Maybe, did y'all cover strokes in 201? Okay, maybe 105? Well, you covered it somewhere.
No, we haven't.
Not in the program yet?
I think it might be next.
Maybe next, okay. So,
Take that question out now if it's in there.
check, got it, all right, and I can slip Lantus in, is that a good? Oh, okay, you're trying to limit me there, I gotcha. Okay, so let me talk to you a little bit about TPA so you'll be a little bit more knowledgeable. So, what TPA does, it dissolves thrombus in the coronary arteries. So here's the thing, that thrombolytic agent, the problem is it's not selective for just clots in the coronary arteries. It dissolves all clots. You can see how that might be an issue, okay? It is most effective when given within the first 6 hours from the onset of that chest pain. That's why we ask when you come in, hey, when did your chest pain start? If it's after that 6-hour window, oftentimes your healthcare provider will choose not to give it just because the benefits don't outweigh the risk there. Also, there's contraindications. You can't use TPA for every single patient that you have. So you got to be careful with that. You have a chart in your book. Let me tell you where it's at. Okay, it is on page 761. And it talks to you about TPA. Okay. And it talks about contraindications. It talks about absolute and relative. Okay, so absolute means never, ever, ever do you. Relative means, well, maybe, if the benefits outweigh the risk. So when you look on your absolute, some of the things you see here. If the patient has had any prior intracranial hemorrhage, you do not give TPA. Okay? If they have had an ischemic stroke within 3 months, you do not give. If you think they have an aortic dissection, you definitely don't give. Okay? Or if they're actively bleeding, you don't give TPA. Because as I said, as soon as this TPA is administered, and it's IV, it goes to work dissolving all the clots that person has in the body. So you see how it comes with some risk there? So those benefits definitely have to outweigh it. Okay? So when you're taking care of a person who's getting TPA, you can anticipate one of the side effects would be they would have some bleeding. Okay? And when you look at this, what you have to think about, it's the degree of bleeding. For example, if I have given somebody TPA, they're in the ICU setting, or not ICU, let's say they're in the ER setting, okay? And they start throwing up because something else was going on, and they want to brush their teeth. I can let them brush their teeth, but the patient calls me because when they brush their teeth, they notice they have a little bit of oozing around their gums. That's anticipated. You would educate and say, thank you for letting me know. You know, you might see some oozing when you brush your teeth. You might even see that around your IV sites you have a little bit of oozing right there because it's dissolving all the clots throughout. Thank you. Keep me aware of it. However, if after talking I go back in there and let's say it's Jay and I'm just trying to talk to Jay and Jay just starts talking crazy or I have a hard time waking him up, I'll be like, what should I anticipate's going on? Bleeding in his brain. So you see how it's the degree. Now if that happened, I'm going to be out there and get me a healthcare provider. Come on, you can come in here. Jay's not like he was. We got something major going on. So you see what I mean? It's the degree. You would anticipate oozing, and you would definitely document around your IV sites, anything that was in them that was foreign, you would anticipate that, okay? But you still got to make sure you're doing those frequent neuro checks because one of the side effects could be you could actually have bleeding in the brain. And like I said, we're really good when we see the blood. Like when we visually see it, we're like right on it. But it's the ones that we don't see that sometimes take us a little longer, okay? So in addition to things like neuro changes, any complaints of abdominal pain you really want to follow up, this could be bleeding inside. So that's what I mean. You got to be really careful and do frequent checks on these people. Any change in their neuro status requires an immediate follow-up, okay? After TPA, what we like to do, we like to give heparin because what heparin's going to do, it's just going to facilitate. So with the TPA, we broke up all the clots. Now we want to make sure it stays nice and thin, their blood does, so they don't get a reocclusion, so we'll keep them on heparin for a while. Your hospitals have heparin protocols, so you would follow your heparin protocol, and your physician determine how long he wants that individual to be on, or she to be on heparin. Other medications you're going to see, beta blockers, okay? You're going to get so tired of beta blockers by the time cardiac's over, but you will know what it is. So here's the reason that we like to give beta blockers. One, current evidence-based practice shows that beta blockers decrease the mortality rate by 23% just by giving a beta blocker. So if there's no contraindications, we do it. The other thing that we have found with beta blockers, they decrease the likelihood of developing a ventricular dysrhythmia. That's very common after MI is to develop a dysrhythmia. So we're going to try and prevent that by giving them a beta blocker. It also reduces the size of an infarction. Because remember, it makes the heart work smarter, not harder. Nitrates, again, increase collateral blood flow. It's going to dilate those coronary arteries. It's going to help get blood to the area. ACE inhibitors, so we like to give ACE inhibitors, or sometimes we call them ARBs. So either or, and we like to give it within 48 hours. Okay? And the reason we like to give it within that 48 hours is it prevents ventricular remodeling, okay? And the development of heart failure. So let me tell you what I mean by that. When I say, do y'all know what I mean when I say ventricular remodeling? Okay, so let me show you. So remember this zone of infarction? Your heart's a muscle. If you don't use it, you lose it, okay? What I mean by that is, this area right here, this zone of infarction, is always going to be weaker. So what happens is the areas around it kind of become a little bit bigger, a little bit more developed to try and compensate for that. Well, the heart doesn't like that. And the reason why it's most effective in the current shape it's in. So then what we do is we give ACE or ARBs, and it keeps it nice and smooth in this same shape. So I want you to think about, compare it to your leg. Okay, let's talk about your calf muscle. Let's say I lose part of this calf muscle. So that area right there, my shape's not going to stay the same. That area is going to be smaller than the rest. The problem is it's not going to function as well. It's going to be tired. It's going to have a lot more problems getting the blood flow through. So it's the same premise there. We want to try and keep the heart in its ideal shape. We want to prevent any type of remodeling. We want it to stay in its normal size. So that's how we give it, okay? Because the problem is when you start changing the shape of the heart a little bit, it can lead to increased workload of the heart, and that can lead to heart failure, okay? So that's what we try and give those to try and prevent any type of remodeling, change in that ventricle from occurring. The other things that you will see given, we like to give, again, calcium channel blockers. It's just going to help with vasodilation. We give morphine for the pain that's associated with a myocardial infarction. Now, a lot of people like Dilaudid, okay? And Dilaudid is a great and wonderful drug. However, if the pain is truly cardiac in nature, morphine's going to help them more than anything else. Because what morphine does, it relaxes smooth muscles, okay? So while relaxing smooth muscles, the other thing it's going to do is going to decrease the O2 demand. Okay? So that's why we give morphine for the pain versus any other IV narcotic. Okay. You have two great drug charts. You have one on page 758 and you have one on page 766. Most of what I presented for you is on that page, or on those pages. And then I would also strongly encourage you to read between 755 to 761, and it talks about the medications, okay? The other thing you need to be aware of, I just like to introduce you to complications that could come from a person having an MI. I don't go into a lot of detail because if someone has complications from an MI, they're in the unit and you get that material. Dr. Dubose will cover that in 203. But I do want you to kind of be aware of some of the problems they can have. One is a cardiac tamponade, okay? So when you think about a cardiac tamponade, essentially what's happening here is you have an accumulation of fluid between the myocardium, that's the actual heart muscle, and the pericardium, that's that outer covering, okay? So you have all this fluid buildup. Well, that fluid buildup, what happens is the heart is not able to pump blood effectively. It can't get it out. It can't squeeze it all the way. So it starts backing up. So we have something that's called Beck's triad. It's what your patient will experience and what you will see. So for example, you will have distended neck veins because the blood's backing up. So they'll have real big jugular veins, and they'll just kind of throb a little bit. Your patient will have distant heart sounds, because think about it, you have to hear it through all of this fluid, so they'll sound very muffled. Okay? And then they'll also become hypotensive, because again, blood's not perfused into the body. This is considered an emergency. The only thing that we can do for someone who has this complication is we have to drain the fluid. Okay? So they insert a needle into this, in between those spaces, and they drain the fluid that's accumulating. Okay? It's considered an emergency. Another thing that often happens following MI is something we call a rupture. So typically the rupture occurs in the area where the MI, that zone of infarction, is typically where it occurs, because that zone, it's weaker than the rest. So essentially it just tears, because that's what a rupture is, a laceration or a tearing. It comes on very, very suddenly. Prognosis is very, very poor. Most people don't survive it. Because think about it. Remember, a tear is a laceration. So this person has a laceration in their heart. It's not like it's easy, we can get to it and just suture it up. So most people do die when this happens, just because of the sheer time factor of having to get them open and fix everything, okay? So when you talk about a myocardial rupture, just realize that outcomes are very poor, okay? It's a myocardial or a ventricular rupture. Okay? Another complication that can occur is an aneurysm. So remember, an aneurysm is an outward ballooning in the wall of the heart. It's usually where that zone of infarction is, because remember, that area is very weak. So what happens is the aneurysm will cause an outward ballooning. Well, the problem with that, it increases the workload of the heart, okay? And it leads to an ineffective muscle contraction. Well, that will lead to cardiac enlargement, and guys, that leads to heart failure, okay? And their prognosis primarily depends on the size of the aneurysms. People with smaller aneurysms fare better than people with the larger aneurysms. But these are all complications that can arise from having an acute MI. Another one is shock. When you think about shock, guys, realize that up to 20% of people who have an acute MI, they will develop cardiogenic shock. So shock is just defined as the heart's inability to effectively pump blood throughout the body to meet the metabolic demands of our tissues and our organs. Essentially, your heart just can't pump enough blood out to meet the demands of your body. It's trying, but it just can't. Okay. And guys, in that 20% of people who will develop this cardiogenic shock, about 80% of them will die. So typically what happens is the patient will very suddenly become very pale, have a weak pulse, they'll be very sweaty, they start developing very rapid breathing, they'll have a very thready, irregular pulse, and they'll become hypotensive. Okay? They can even lose consciousness. Because the problem is all of our tissues need oxygen, but the heart is just not able to supply it. Okay? So that being said, our goal is we have got to immediately reperfuse. So oftentimes what happens is they need to go back in and have, like through a cardiac catheterization, and whatever vessel is occluded, they have to reopen it. They reopen it, they'll be able to reestablish that blood flow. So what we'll do until that is able to happen, we'll put them on an intra-aortic balloon pump. What that balloon pump does, it's just a short-term fix. That's one thing you have to realize. You can't be on a balloon pump for an extended period of time. But they'll just be on this balloon pump until we can get them to the cath lab or operating room where we can open them back up, maybe do some angioplasty, restenting of whatever vessel has become occluded. Okay? But again, it is a very serious complications that has a very high mortality rate. Now, I want you to realize the most common complication following acute MI, dysrhythmias. Okay. So you gotta know your dysrhythmias, guys. We're gonna do a little intro to them. Okay? So we are gonna start next on introduction to the cardiac conduction system. Okay? Is where we're going next. So what I need you to do, I just need you to get one sheet of paper. Put your name on it. A little scrap sheet of paper, it's fine. If you don't have some, I think I got some scrap paper up here. So kind of clear your desk just a little bit so you have a place to write. And put your name on this sheet of paper.
Your bonus points.
I need to know where to start at. This tells me where I need to start
From the
at.
very beginning.
Very beginning. on this sheet of paper, make sure you put your name. And I need you to, and, oh, I should say this. It is your own knowledge, not your neighbor's knowledge, not your book's knowledge, not Google's knowledge. Your knowledge, okay? Blood flow through the heart. Go for it. What? I know it might have been a while, but you got it. I'll give y'all just a few minutes to do that. Once you do that, if you will flip it over on the back. Don't look at me like that. Okay. I want you to tell me the cardiac conduction system. What? Impulse starts here, and then it goes to here, and it goes to here, you know. Maybe. Okay. Show me your knowledge on the paper. It's a starting point, guys. Don't worry, we have 3 weeks.
3 weeks?
Well, since we started
Oh,
before our next test.
I'm thinking like, I'm counting today.
Oh, okay.
I don't know about 15 for today.
I got you. I got you.
I can give you number 1.
Well, write number 1 there.
Um,
No, don't be telling everyone. Don't share your knowledge yet. Just write it number 1
oh,
on
you're talking about
there.
blood flow through the heart, right?
No, you're
Oh, that's
telling
what, oh,
me
I'm sorry. That's
conduction
what,
system.
oh, I'm sorry. No. I can't give you number 1 on that.
Okay. And when you, can I? Hey, that's not bad. You're just missing 1. Is it, like I said, y'all got time? You got time. It's okay, it's okay.
From the beginning.
From the beginning, got it. So let's talk about, does this look familiar now, a picture?
Mhm.
Starts in the essay note.
Oh, okay, yeah.
Then the, oh, don't be acting like you know it now. Okay, so here's the thing you have to realize. Remember, electrical impulses are caused by pacemaker cells. Pacemaker cells are pretty cool. They're located they should only be located in the heart. So what happens is, these electrical impulses, they transmit electrical activity to other cardiac cells. So remember, when they transfer all the electrical energy, that's called conductivity. So your SA node is where it all begins, guys. Your SA node is considered the dominant pacemaker of the heart. So when the electrical impulse initiates in the SA node, then the person will have a heart rate of 60 to 100 beats per minute. Then what happens is, once it's in the SA node, then it's going to go down to the AV node. Once it's in the AV node, it's going to hold it it's going to give it just a brief little hug, and then send it on its way down to the bundle branch system. And that, guys, completes conduction. Okay? So it always goes SA node, AV node, bundle branch system. Boom. SA node, AV node, bundle branch system. Boom. SA, AV, bundle branch system. Boom. Heart rate. Okay? So if it initiates in the SA node, then the person's heart rate is going to be 60 to 100 beats per minute. Okay? That's normal. That's what we want everybody to have, right? We're all good with that? Okay. Well, what happens is, sometimes our dominant pacemaker, it gets messed up. Or for whatever reason, it doesn't work. But it's okay, because you have escape pacemakers. If your SA node doesn't work, well, then your AV node will try and take over. And it tries to do a really good job, but your heart rate will only be between 60 to 40 beats per minute. Okay? And if for some reason, guys, your AV node doesn't work, well, then that poor little bundle branch system, they will try their hardest. But look at what that person's rate's going to be. They're not doing so hot down here, 40 to 20 beats per minute. But they're trying. Okay? So this right here, guys, is what we're going to look at today. We're going to look at the electrical conduction system through the heart. And I'm going to tell you how you find it. You look at an EKG. So an EKG is just an electrocardiogram. You typically know how long a nurse has been practicing by if they call it an EKG or an ECG. Okay? I will try and say ECG, but oftentimes I refer to it as an EKG because that's just how I always refer to it as. But guys, we can tell so much from an EKG. When you're looking at an EKG, realize we use these to monitor a patient's heart rate. We can use it to evaluate the effects of disease or injury on the heart, function. Hey, we can even use this to evaluate pacemaker functions, okay? It lets us know how the heart responds to certain medications, for example, like anti-dysrhythmia medications. And we can also do EKGs either before, during, or after a procedure just to kind of get a baseline to figure out what's going on here. EKGs also let us know if there's been any type of ischemic damage. So we can tell a lot from an EKG. It's just a graphic representation of the heart's electrical activity. So some key points to remember when you are doing an EKG. One is we typically like our patients to be in a semi-reclined position. We want them to be breathing normally. Their little telemetry pads or their little EKG tabs, we don't want it to be put on irritated or scarred tissue because it doesn't conduct as well. Okay? So when you're looking at an EKG, one thing you have to realize is you have to use EKG paper. This is an example of EKG paper that I'll pass around and y'all can look at. But EKG paper, it might give you some flashbacks to like geometry when you have the little boxes, because that's kind of what it reminds me of. But each one of these little boxes means something. Okay? So when you look at EKGs, you have a horizontal axis and a vertical axis. The vertical axis deals more with amplitude, and so we're not dealing with that too much in this class because we're a baby EKG class. So we deal more with the horizontal. Horizontal equals time, okay? So when you look at your EKG paper, one thing you have to realize is every one of these boxes that you see is 1 millimeter by 1 millimeter, okay? And the reason that's important is every little box is 0.04 seconds. Okay. Now, I have not found an easy way to remember. You just have to remember these times, okay? So here you go. Just remember it. And the reason this is so important is because we read strips on 6-second strips. So we have to be able to find 6 seconds, right? So here's the thing. 5 large boxes, each consists of 5 smaller ones, that's 1 second. Okay? 15 large boxes is 3, and then 30 large boxes is 6. But we have this neat little thing, and it's in your book too. So if you look on page, what is that, 641, figure 31-4, it kind of shows you how it is. So the easiest way to read it is you use your hash marks, okay? These hash marks, that represents 3 seconds. So this would be 3 seconds, this would be 3 seconds. So you read on 6-second strips. So then therefore, instead of counting 30 small boxes, because y'all might have good eyes, but mine aren't that good, you use your hash marks. Here to here, hash mark to hash mark, 3 seconds. Okay? So for testing purposes, it is safe for you to assume that every strip that I give you is a 6-second strip. I don't want you to have to worry about counting it out right now. But when you go to clinical tomorrow, what I want you to do is I want you to get in your patient's chart, or if your person has electronic chart, look at your EKGs, and I want you to look at your hash marks. Count your boxes. Okay? So that's your challenge tomorrow. Look at an EKG, see if you can figure out where your hash marks are and count out 6 seconds, hash mark to hash mark. The other thing I want you to do is that when a person has an EKG, they look at different areas of the heart. So you might have, beside each line, you'll have like Roman numeral 1, Roman numeral 2, Roman numeral 3. Okay? In your book, it gives you a great little example on figure 35-5. If you look at the strip, that's Roman numeral number 2 because it has a little 2 out beside it. Like right here. Okay, you see how it has that 2? So that's lead 2. And the reason that's important is because when you read, I want you to read in lead 2 because that tells you overall how's the heart doing. Okay? No, it's
641.
Yeah, 641. Okay? So the other thing we need to realize is when we talk about EKGs, we first, before we start talking about any cardiac cycle, guys, we got to define baseline. Baseline is where everything starts from, where everything comes back to. Okay? So for example, your P wave is the first wave in the cardiac cycle. Before I can find a P wave, though, I got to find my baseline. So let's look up here. Let me show you where your baseline is. Okay? This is your baseline. Okay? You see where it starts to deviate up? That is the beginning of your P. Your P represents the firing of the SA node, so it's like starting everything off, getting ready to go. Okay? So it starts to deviate up, and then you see it go, it keeps going until it returns back to baseline. This right here is your P wave, guys. It's the first wave in the cardiac cycle, and again, it represents atrial depolarization, okay? So some terminologies you need to be familiar with when we talk about EKGs and reading, okay? This is baseline. As I said, everything starts from baseline and comes back to baseline. Things can be positively deflected if it's positive, meaning above, okay? So positive means above. So I usually will always, when you're starting out, put a plus up here. This is above baseline. Okay. If it's below baseline, it means it's negatively deflected. So I always put a little negative sign down here, because you can have things that are positively deflected and negatively deflected. Okay? So when you look at a P wave, what I need you to realize is that when you're looking at this P wave, we recognize it as the first abrupt or gradual deviation from baseline. Okay? So for example, this is baseline, guys. You see how it starts to come up? This right here is the beginning of my P. And I follow it, and when it comes back to baseline, that's the end of my P. This right here represents what's going on in the atria. It's the firing of the SA node, okay? So when you think about your P's, remember a normal P should be smooth and round. It should look like a little hilltop. It should kind of be equal on either side of it. It should look nice, smooth and round, okay? It should also be upright in lead 2, which is, remember that's the lead I want y'all reading in, so it should be upright, okay? It should be no more than 2.5 millimeters in height, and I tell you it should be between 0.06 and 0.11, okay? So those are your normals. Now, you know if I give you normal P's, I've got to show you some abnormal ones, okay? Because that's just how it is. So let's point everything out first. Baseline. Is everybody good with this being baseline? It's the point where everything starts and comes back to. So you see where it starts to deviate up? This right here is the beginning of my P. You follow it till it comes back to baseline. There's my baseline. You see how this P right here is smooth and round on both sides? This is a normal P. So this is P, QRST, here's another P. Baseline. Everybody good with baseline? Okay. You see where it starts to come up? So that's the beginning of my P. And you follow it around, and here's the end of my P. What you noticed about this is something we call a notched P. Okay? So usually in notched or even peaked T, there is something that has enlarged their atria. And for example, they could have like COPD, congestive heart failure, something that's made their atria enlarged, and that's what's causing these abnormal P's. Okay? But this is considered a notched P. This one is a peaked. So here's baseline. You follow it. When you look right here, you see how it comes up from baseline? And you just follow it, and here it comes back to baseline. This is considered a peaked P. Okay? Another type of abnormal P that you might see in practice is something called inverted P. Here is baseline, and when you follow it, you see how your P is not positively deflected, it's negative deflected, meaning it's below baseline. This is what we call an inverted P. So typically with your inverted P's, you see those in more of your junctional rhythms. Those are like your really, really slow rhythms, is when you'll see some inverted P's. Okay? So P represents the firing of the QRS and lets us know what's going on in the atria.
With that notch, is that similar to like the PAC, the mid-shaped P wave? Is that the same thing? Notched P wave and misshaped P wave?
So you can call it misshaped if you want to call it. It's just not like this.
Right.
Because this is, you compare everything to this P. This is a normal P. So anything that's not like this is considered misshapen, and I think that's kind of when you're doing your reading, that's what they talk about. But usually in clinical, we just call these notched or peaked. Okay. So the next wave is the Q wave, guys. Your Q wave is the first negative or downward deflection that follows the P wave. Your Q wave should always be negative. Okay, so remember the reason that's important is our QRS complex begins with the Q wave. Okay. So let's work on baseline and build it all together. Here's baseline. Does everybody go with baseline? Okay. You see where it starts to come up? This right here is your P. And then you follow when it comes back to baseline. You see where it comes back to baseline right here? Okay. So your Q is your first negative or downward deflection following the P wave. So you see here's baseline, you see where it starts to come down? This is your Q. Okay? So after your Q, guys, you have your R. Your R is that positive following the Q. Baseline. This is the beginning of your P. Here's the end of your P. Okay? Baseline. Here's the beginning of your Q. You see where it starts to go down. And then where it goes up, this is your R. It's positive. Okay? Then you have your S. Your S is that negative waveform that follows the R. Baseline. Beginning of your P, end of your P. Baseline, beginning of your Q. Here's your R, comes back down below baseline. Here's your S. Your S ends when it comes back to baseline. Okay? Those three waves, that is what we refer to as the QRS complex. The QRS complex lets us know what's going on in the ventricles. Okay? So when you talk about a QRS complex, normally you should have one after every P wave. Okay? Again, it should, a complete QRS complex has the Q, the R, and the S wave. Okay? And again, what it represents is the spread of that electrical impulse across the ventricles. So let's talk about, if I show you normal QRSs, I got to show you some abnormal ones, okay? So a normal QRS, as I tell you right here, and you need to fix your slide because your slide is incorrect, okay? So what it tells you here is an abnormal QRS complex is less than 0.06 or greater than 0.10. I think the slide you printed out said 0.04, so change that to 0.06. Because they updated it in the new edition of the 10th edition. It's been updated. Okay. Anything less than that or greater than that is considered abnormal. So things that would make it wider, if they have some type of, or I should say, if the impulse originates in the bundle branch system, then it makes the QRS complex wider than what it should be. So the last, one of the last waves I want to show you is your T wave. Okay? So your T wave, you measure it from, well, here, I'll show you right here. Okay? So baseline, everybody's good with baseline so far? Okay. Beginning of my P, you see where it starts to deviate up? You follow it, it comes back. Okay, so it's returned to baseline. Okay, So here's baseline. You see where it starts to deviate down. This is my Q. Follow it. There's my R. Comes back down below baseline. S comes back to baseline right here. Okay, so my T wave is right here. It's my first positive deviation following my QRS complex. Okay, so this is my T wave. So what your T wave represents, your T wave represents at the beginning, it's like your absolute refractory period. Your heart's like, whew, I'm tired, I'm resting, okay? That's at the beginning of your T. And at the end of your T, it's like, okay, I'm getting ready for that SA node to fire. So that's kind of what your T wave represents. It's that ventricular repolarization, okay? So when you look at T waves, some things you need to realize. One, your T wave, it's normal for it to be slightly asymmetrical. What I mean by that is, you know how I told you like your P waves, I want you to think about them like as little hilltops, so they're kind of the same on either one. Well, with T waves, it looks like a little mountaintop. It's slightly asymmetrical. For example, like right here. You see how this one's a little different than that one? It's like you gotta climb up the mountain to get to the top. Okay? So this is a normal T wave. So if you were looking at it, I can't do anything because I don't have all mine, but here's P, QRS, T. Okay? P, QRS, look at that T. It's going the wrong way. No, my paper's not upside down. It's called an inverted T. Okay? If you see these inverted T's, as I tell you, it could mean that they have some type of ischemia. So we worry when we see inverted T's. Okay? So let's just keep following it. P, QRS, T. Here's another example of inverted. Again, sign of some type of ischemia. So the other problem that we can have is we can have something we call peaked T waves. When you look right here, P, QRS, T, P, QRS, T, you see how these T waves are so large? That's not correct. Typically, if you see peaked T waves, what you better be looking at is what's my potassium level. What's your normal potassium level?
3.5.
3.5 to 5, yeah. So in this situation, what you will find is it will be normal, higher than normal. Okay? And the reason we worry about that is it can cause some ventricular dysrhythmias. Okay, so we get worried when we see these peaked T's. The other components you need to be aware of, one is your PR interval. Okay, and when you do your reading, I think in your reading, some areas it'll call them segments. Don't let that confuse you guys. An interval and a segment are the same thing. Okay, but when I was doing my reading, I was like, okay, sometimes they're using segments, sometimes they're saying interval. It means the same. So what your PR interval tells you, it tells you how long it takes for an electrical impulse to get from the atria to the ventricles. That's what it's telling you. Okay, you measure your PR interval from the beginning of the P wave to the beginning of the QRS complex. Okay. So, as I have right here, this is baseline. I feel like we're all pretty good with baseline, right? We're all good with baseline? Okay, here's baseline. Right here, where it starts to come up, that's the beginning of your P. So you measure from the beginning of your P to the beginning of your QRS complex, which is right here, the beginning of your Q. So sometimes the name could be a little misleading because it's not actually, you're not going all the way to the R, you're going to the beginning. Okay? But this area right here should be between 0.12 and 0.20. So no more than 5 small boxes. That's really important in telling me how long it takes an electrical impulse to get from the atria to the ventricles. That's its whole purpose there. Okay. The other interval that we look at the ST interval. Okay. So the reason we worry about ST is because if we have elevation or depression, that could be a sign of myocardial injury or ischemia. So we take those really seriously when we see any type of deviation in the ST interval. So we measure the ST interval from the end of the S wave to the beginning of the T wave. And it's not really big, guys. It should be no more than 0.04. Well, remember 0.04, that's one small box. That's it. That's all it should be. Okay? So, the baseline, beginning of my P, end of my P. Baseline, beginning of my Q, R, S, it comes back to baseline here. So this little area right here is your ST segment, okay? It should be no more than one small box. If we have this really, if it's really high or it's really low, then we're concerned about ischemia. And the only other wave I like to present to you, because I know as soon as I don't present it, you'll see it in clinical practice and you'll be like, Dr. Daniels never told me about that. So you can't say I never told you about U waves. However, they are actually really hard to see, okay? You usually only see them in lead 3, which not too many people read in lead 3. But if you see a U wave, it's a very small wave that follows the T wave, okay? So it's usually about a third the size of the T wave. So for example, okay, there's your T, and you see it's about a third of the size. So let me tell you what this U wave could mean, okay? The reason we're concerned if we see a person has U waves is it could be indicative that they have a low potassium level. Not always, but it could potentially mean that. So if you see someone having these U waves, the first thing I want you to think about is, what's their potassium level? Go to the chart and look, is there a recent potassium level? If not, you would anticipate the physician ordering one, because we don't know if it's that person's normal or if maybe they have a low potassium, okay? So that's just what I like y'all to realize, that you could potentially see it. We don't know why some people have U waves, but we do know that the reason some have U waves is because they have a low potassium level, but that's not the case in every single individual, okay? So guys, this is everything that we just covered. If I want to know what's going on with the atria, where do I look? P wave, absolutely. If I want to know how long it takes for a electrical impulse to get from the atria to the ventricles, what do I look at? PR interval, absolutely, okay? If I want to know what's going on in the ventricles, where do I go? Yeah, your QRS right here, okay? And so remember, in your T wave, what's going on is at the beginning, that's like your absolute refractory period. Your heart's like, I'm done, I'm tired, okay? But then at the end of it, it's like, okay, I'm getting ready, I'm getting ready, I'm getting ready. And it's going to come back and start over. Boom, SA node firing, okay? That's everything we just covered, guys. So what I want you to do, let's take 10 minutes.
Yes.
Are you saying you just have so much knowledge right now?
Just gotta use the restroom.
Okay. Okay, so let's come back at 1:50, and we're going to start. My goal is to finish normal sinus, sinus brady, sinus tach, AFib, A-flutter, okay? I always like to tell you, you're going to feel overwhelmed when you walk out of here. It's okay, everybody does. Just got to practice, okay? So go take you 10 minutes. I will start back at 1:50.